what are the do's and don'ts as it relates to, I don't want to use the word optimizing. It's gotten me into trouble before because the word optimize or optimal suggests that there's a perfect number that one should all attain if possible. But in reality, optimal is a day-to-day thing, at least. But what should people avoid in order to get their sperm quality as high as possible, their testosterone level? Again, here I have to be careful. I don't want to say as high as possible because some people might not want excessive androgen. But at the high end of normal, perhaps would be the ideal for many people. What should people do? What should they avoid? And here I'm setting aside any prescription clinical treatments that, such as testosterone injections or things like chorionic gonadotropin, human chorionic gonadotropin, things that we can talk about a little bit later. But what should every male be doing in order to optimize these health parameters?
Yeah, so I think that there are some risk factors that we do. Like we'll start with semen quality. So we talked about heat. I think that's a big one. So like hot tubs, saunas, try and avoid those. Some light data on seat warmers. Anytime we kind of get this external heat source to the scrotum. The testicles are outside the body because they need to be a little cooler. So anything that warms them up can certainly be a problem.
Could I just briefly interrupt there to ask? We've done episodes on sauna and some of the health benefits of sauna. Is it sufficient for somebody to bring in a cold pack to the sauna and put that in their groin? I actually have suggested that. That's actually what I do when I go into the sauna. And I have suggested this on podcasts, not just for people who are trying to conceive, because it seems like heat, as you mentioned, is bad for sperm, not quite as bad for testosterone levels. But is it also true that heating the testicle too much is generally bad for endocrine function in males, and therefore if one is going to go into a hot sauna for 20 minutes or more to essentially cool the scrotal area?
Yeah, I think the spermatogenesis or sperm production is certainly a lot more sensitive. Whether you can sort of thwart the effects of external heat with a cooling pack, I think it makes sense. There are studies that have looked at different ways to cool the scrotum and have compared, semen quality before and after, and there's some data that may help. It depends how long you're going to spend in the sauna and how cold, that pack is going to remain.
So ice pack and in the sauna for 20 to 45 minutes.
Yeah. And is the ice pack still cold afterwards?
Yeah. Yeah, they actually sell, and by the way, I have no relationship to any of these companies, but they actually sell cold packs that are designed to be worn in your shorts. So if you go to I'll go to a Russian banya every once in a while. Now I guess I'm outing myself. Yes, I have a cold pack in my shorts when I go to the Russian banya. But they have a sort of an insulation so that the very cold surface is cold enough, but it's not right up in contact with the scrotal skin, because that could get, I want to make a bad joke and say it could get sticky, that situation. You don't want it being so cold that it actually would stick to the skin, and then it could potentially damage the skin when you try and remove the cold pack. So it has a thin insulating layer. That's essentially what it is.
Yeah. Frostbite to the scrotum is not theoretical. It could certainly happen. So you do want to be careful.
Yeah.
So, in theory, that should be adequate to sort of, to decrease the risk of that particular effect. I keep coming back to health, how important that is to maintain, adequate sperm production, because I think these two are very linked. There have been studies that show that men with more comorbid conditions, so obesity, hypertension, hyperlipidemia, as these sort of stack up, we see a decline in testicular function, so lower testosterone levels and lower sperm quality. So I think, taking ownership of your health, I think, is important as well. A lot of times, fertility tends to be one of the first touch points that some men have with healthcare, because generally what brings men to the doctor, it's usually pain or, kind of a problem. So, if men are in their 20s and 30s getting ready to start a family, or 40s in some cases, sometimes they haven't, seen a primary care doctor. So some of these things, some of this relationship has not been established yet. So I think, thinking about ways to start that, I think would be important too. And then I know you don't want to talk about testosterone, but testosterone is actually a fairly common problem that we see in fertility clinics. I would say that estimates say maybe about 1 in 20 infertile men are that way because of testosterone. So I think when people get testosterone from different places, and hopefully whatever provider you're getting it from tells you that one of the side effects of this is lower sperm production. It's actually been tested as a contraceptive, and with some other agents, it can actually be fairly effective. So We just want to make sure that, if men are starting testosterone, they're doing it for the right reasons and they're doing it safely. I think
you're talking about testosterone replacement therapy. Although, as we were talking about before we started recording, I am really on a push now to rename what people call TRT, testosterone replacement therapy, because indeed some people have low testosterone and need it replaced, the
Right.
R in TRT. But I think what you're referring to, if I'm not mistaken, is that there are probably millions of young men and older men taking exogenous testosterone, injections, creams, pills, pellets, any number, nasal sprays now, any number of different routes of delivery of exogenous testosterone, and that dramatically reduces one's endogenous testosterone production and dramatically reduces one's sperm count and maybe even quality. We'll maybe talk about this a little bit later, but maybe even I've been told that it can perhaps introduce a DNA fragmentation within the remaining viable sperm as well. So do I have that correct? You're saying that you see 1 in 20 men have issues with fertility because they are taking testosterone.
Right.
So their testosterone levels presumably are going to be high-end normal or more, but they are doing presumably not testosterone replacement therapy, but they're doing what I call testosterone augmentation therapy, meaning they were somewhere in the 300 to 900 nanograms per deciliter range, but decided to start taking testosterone anyway, and then their sperm count essentially diminishes to nil or close to it.
In some cases, yeah. So, I think there's various reasons that you would take testosterone. I think, some people have been treated, years ago, and so they do need to replace testosterone, but some people do it for augmentation. I just usually say testosterone therapy, just so it's correct.
Oh, you kill the R. I like that. That's better than the TAT, which doesn't sound very good. Okay, just testosterone therapy.
Yeah.
Okay.
But if you had, for example, if we take 100 of my infertile patients that come in to see me in clinic, at least 5 of those men will be infertile because they're on testosterone therapy. And some of them do, have that suspicion. They say, I'm going to level with you. This is why my levels are probably low. But a lot of men were not told that, when they started therapy. So I think certainly for reproductive age men, that's a very important conversation to have, because there can be some other, ways that we kind of maintain sperm production. I think sperm cryopreservation is a good option for these men as well. Or there may be other therapies they can think about just because of reproductive toxicity.
What about HCG, human chorionic gonadotropin? I hear about a lot of people who go on testosterone therapy who take HCG every other day or so. Typically the dosages that I hear about, because people write to me about this stuff all the time, really, it's one of the most commonly asked questions. I get many questions about many topics, but I would say a full 10 to 20% of them are about penises or testosterone.
Those are perfect then.
Right, exactly. So a number of those guys who are taking testosterone will be prescribed HCG to stimulate sperm production, endogenous sperm production, to maintain healthy sperm, presumably because they either want to conceive or are intending to conceive in the future. Is that the best line of treatment for maintaining fertility while people are taking testosterone therapy?
Yeah, that's one of the therapies that we use, and I think it can work well. Just a low dose, usually, again, for those that know, 500 to 1,000 units every other day is usually adequate.
So if somebody is not taking testosterone exogenously, they've gotten their body fat level down to a point where they're not considered obese, so they're hopefully doing some cardiovascular exercise each week, maybe doing some sport or some resistance training too, with the intention of maintaining all-around good health. Stave off, cerebrovascular, cardiovascular issues. What are some of the other don'ts? I'm going to assume that smoking cigarettes or vaping cigarettes is bad. Are there any studies that have looked specifically at vaping and sperm quality or testosterone levels? And is there any evidence that smoking cigarettes is good for testosterone levels or sperm production? Because I'm guessing the answer is no. I feel like nowadays we just say don't smoke, but the data are the data. Who knows? Maybe nicotine can help sperm. I have no idea.
Right. It's possible. I don't think we have the data on that yet. But yeah, I think, like, to your point, I think lifestyle factors are certainly a big one. And, some of these, potentially, kind of unhealthy habits. So smoking is certainly something you should not do. There have been, lots of studies that do link that to, lower quality. Again, all the different measures that we look at. Also looking at fertility, these men tend to have a longer time to get pregnant. Alcohol, I think, is another very common question we get asked as well. And I think for that, there's, I think less of a strong association that we've seen. So there have been some studies that show that very high levels of alcohol, and I guess that's sort of subjective, what some would consider higher or not. But, when you get above maybe 20 drinks a week, there have been some effects. But usually
that's a lot of drinking.
I would think that's a lot. Yeah. But some people don't. But yeah.
I did an episode on alcohol. I think anything more than two, I know people are going to, balk at this, but, I think any more than 2 drinks per week is where you start to see some negative effects on some health parameters. But, I'm not a teetotaler, so,
Yeah. But when you get to this 20 drink, that's when we started to see some effects on semen quality. But the other, the thing about that is that usually if these men are drinking 20, they're doing other things too, smoking, there can be other drug use as well. So it's hard to tease that out, but in general, that's, I think certainly anything in moderation is probably okay, is probably better. And so that's how I counsel patients. I think, again, it's very rare that I see men that are at that level, but I certainly let them know when I do. There's some new data coming out of that we've started to work on, looking at if there are different sensitivities to alcohol. So, some East Asians have a mutation that leads to flushing. And so that may put those men at higher risk. When they mix alcohol, we may see some, slightly lower sperm parameters.
You mean skin flushing because they don't make alcohol dehydrogenase? Is that
exactly.
The idea? Yeah. And is it, I've heard about that in Asian cultures. Is there, in Asian population, but is there any evidence that other populations might have slight variance on alcohol dehydrogenase that perhaps maybe they don't lack it altogether, but they have, I don't know, they're hypomorphs for whatever gene makes alcohol dehydrogenase, and therefore they don't metabolize it as well, and therefore the toxic form of alcohol is active in their system longer. Is there any evidence for that?
No, I think you're exactly right. I mean, I think the one that we think about is East Asian cultures, where it can be, depending on, the region, like Chinese, Taiwanese, probably about 40 to 50% of the population has, mutation in the ALDH2 gene. But other populations, in people with African ancestry, there's a rate of mutation, I think, I'm not going to remember the exact percentage, but I think a few percentage points is some individual with Hispanic ancestry, Ashkenazi Jewish ancestry. So in this particular gene, there's a mutation, not the same one that East Asians have. But, again, I think it gets to why a mutation, where we see sort of negative effects would persist. And the hypothesis that, millennia ago, potentially it, gave some sort of benefit for maybe an infectious disease or something, similar to cystic fibrosis, why, again, this mutation would persist in our population if there's not, some sort of advantage to those carrying it. But we do see other men as well. So I think if, it's a simple question, do you flush? If you flush, then maybe alcohol may have, more of a harm than someone else. And then, again, sort of getting along the lines, I think drug use is also something that we should try and, we do counsel patients about, because that can also negatively affect semen quality.
Do you think it's fair to say that, okay, moderation is best, but if somebody had the option to either not drink or drink in moderation, that they should not drink? Would that be even better? Is there any evidence for that? I mean, it seems like nowadays we take the stance that not smoking at all is better than smoking a little bit. Actually, when I was a postdoc at Stanford from 2005 to end of 2010, you could still smoke on the Stanford campus. I'm not a smoker, but there was this collection of, I have to be careful what I say here. There was a particular group on campus of postdocs and graduate students that would, that would colonize this little area outside the hospital and smoke, because that's where you could smoke. That was eventually eliminated as a possibility. You can't smoke on Stanford campus, as far as I know. But they would smoke right outside the hospital. Actually, a lot of the hospital workers would, take a cigarette on their break. This is very common.
The irony, yeah,
right.
Exactly.
Yeah, and this was common all over the country, right? This isn't unique to Stanford. But nowadays, you just don't see that because it's not allowed. And we here don't smoke. It's terrible for X, Y, Z, and everything, every other letter of the alphabet. With alcohol, we tend to hear that if you're going to drink, drink in moderation. It's not clear exactly what number that is. But is it possible that zero alcohol is better for sperm and endocrine health than any alcohol? Or is that not a fair assumption?
I mean, I think it's a good question. I think, your point about tobacco is an excellent one, because I think any smoking is bad. But alcohol, I think we don't have that data for yet. And so I think it's hard it's harder for me to make that recommendation to patients, especially because, people do it for different reasons. And if it's not necessarily going to help them, it'll harm them in social situations or other things. I usually give the moderation one, unless, again, for the very high drinkers, I definitely talk about that.
You mentioned other drug use. I'm going to assume that unless prescribed for sort of post-surgical pain or something like that, that benzodiazepines, heroin, opiates of any kind are just bad for sperm and testosterone. I think that we could probably make that a short discussion, right?
Yeah.
I can't imagine any of that would be good for reproductive health.
Yeah, that's true. I mean, there's, again, you'd imagine, or maybe not, but there's not a lot of data on it. It'd be difficult to enroll, or maybe easy to enroll, but a lot of those studies have not been done. But there's limited ones of, people in rehab where they have shown, these associations with, addicts or users and lower quality. So, that's how we talk to patients.
What about cannabis? I did an episode of this podcast about cannabis, and I did highlight some of the medical applications of cannabis. I also highlighted that very high THC cannabis may predispose, especially young males, to later psychotic episodes. There are more and more data coming out about that all the time. I got a lot of flack for saying that, but that's my take on the data. I know a lot of people use cannabis recreationally and in a kind of pseudo-therapeutic way. I say pseudo-therapeutic because I think a lot of people use cannabis to manage their anxiety and as an alternative to alcohol for a number of reasons. What is the relationship between cannabis use and testosterone and sperm production? Or I should say sperm quality, excuse me.
Yeah, so this is also a very common question. Again, with this wave of legalization across the country, I think more and more men and women are exposed to it. So again, there's data that the more men are exposed to it, it can lead to some harm in terms of sperm morphology and sperm numbers as well. One of the sort of landmark studies was about 1,200 men, and it found that men that used cannabis daily had significantly lower concentration, motility, morphology compared to those that didn't use it. So I think that's generally how men are counseled, but there's also, other data that shows really a null effect. And I think that it goes into probably the composition, how men are taking it, the frequency, because a lot of that data is not well teased out in a lot of these studies. So, I think I sometimes struggle with this with patients because some of them are taking it for, some what they consider legitimate reasons, anxiety, sleep, pain. And if there's not sort of very convincing evidence that it's going to help, and they're taking it maybe lower than the threshold where I know that there's good data that'll cause harm, I guess I try and be sort of honest about where we are. But I think with a lot of things related to sperm, I think our level of evidence is not great.